Singh ji. Dear trainees, welcome. Now we are almost full strength with the new batch joining, both the counseling over. Now it's about 2 months, 1.5 months. We have the first years who have joined with us. So it is extremely important for us to understand, if you want to learn any topic, the best way to go through that actually is to run through a debate. Remember, in medicine, for that matter, not just oncology, there is no absolute yes, and there is also no absolute no. So the most important way to analyze and take a topic ahead would be to actually debate the pros and cons and understand both coins. So what better way to understand the most controversial topic, which has a very good merit? Should we operate in stage 3 or not? Because optimal treatment of this particular thing, does it entitle surgery with chemoradiation or no surgery, go? So here today we have two very good students, Dr. Dhara and Dr. Zalak, who is going to present for and against these topics, which will be 20 minutes, followed by about a minute debate. Then to interpret this, remember, we are all just budding students. We think it is like a duckling. Anything which looks good, we follow that. But it needn't have to be right. It is not how you read the conclusion of a trial, but how you read in between the lines of a trial, unbiased, without conflict of interest, what gives the importance to that topic. The strength of a student is not blindly to believe, oh, okay, today, Dr. Somshekhar or some of your teachers say, this is the best treatment, this is the treatment to do because I do it. Wrong. Be unbiased, be scientific, understand the strength of those trials, go and try to read in between the line. For that, you need mentors, teacher. So who better than two stalwarts in the field of thoracic oncology in India, Dr. Prashant and Dr. Saravanan. Dr. Prashant is a surgical oncologist, MCH from TMH, and he has got an award as a best outgoing student and also 10-year excellency in Homi Bhabha National Institute. He has done fellowships in thoracic oncology and VATS in MSKCC, MD Anderson, and also Shanghai, where I was also worked and got trained. He has several publications. Excellent. He's somebody who will not believe any trial unless he reads A to Z, understands the strength and weakness, and unbiased he interprets. So he's one of our great expert who has taken time. Thank you very much, Prashant. Welcome. Then we have Dr. Saravanan, great friend of mine. I always admire his energy. And he's regarded as one of a guy. He has done more than 1,000 VATS thoracic surgery in India. If you want to learn, these are the two people where you need to go and learn VATS. And then he also does large volume of robotic lung resections. His area of interest is lung preserving surgery, lung reduction, volume reduction surgery in the field. And he has done various fellowships, and he has also affiliation to International Association for Study of Lung Cancer. Two well-trained, qualified surgical oncologists voluntarily by choice took up great volume of their work in thoracic oncology. So welcome both of you in your busy schedule, especially in the places where network is poor. You are with all of us in Congress here. Thank you very much. And over to Dhara first. Let the debate begin. Thank you.
Good morning, everyone, for all the respected teachers and my colleagues. Today's topic is the role of surgery in stage 3 lung cancer, non-small cell lung cancer, and I'll be speaking for surgery, and I'm Dr. Dhara Pandya. To start, my debate arsenal, I'm going to talk about the history of the thoracic and lung surgeries, the staging and the appropriate workup. I'll be defining the resectable and the unresectable stage 3s. I'll be speaking on the management of the resectable stage 3 with evidence and comparing the available data and summary. Now comes to the evolution of the thoracic surgery. I would like to mention here the timeline through which the thoracic surgery has evolved. We can see it dates back to 2500 CC, where esophageal wounds were sutured from, and today's era of the RATs and the VATs. What I would like to point out here is the lung. We see that the first resection was done in 1499. This was probably for trauma, and then it has evolved from first pneumonectomies to lobectomies in early 1900 to the, I can tell you the mediastinoscopy was somewhere in 1954, and the first VATS meeting was in 1992. Next, comes the evolution of the lung surgeries with respect to the malignancies. This is the first lobectomy specimen that you see. This is dating back in early 1900s to the middle era where pneumonectomies were dominated by thoracotomies, open thoracotomies. Now we are moving on towards the segmented resection to the present era where thoracotomies, we are at a diversion right now where thoracotomies as well as the bats and rats has been taken up even with the uniport and the multiport looks in the picture. Now, coming to the caveat of this debate, it's going to be the staging difference, that is the 7th and the 8th edition. As we can see, depending on the size, the T3s and the T4s have changed. The distance from the bronchus and the diaphragm invasion has changed in the 8th edition. This table clearly shows the 3 different grades of blue that is showing the stage 3 that we are going to talk today. Needless to say that stage 3C and 3B, these 2 shades of blue, we right now have a definitive chemo RT for these people. But also needless to say that the early stages, that is the 3A, that is T4, N0, N1, we do go ahead with surgery, unless of course the pancreas tumors and all where we have to go with definitive RT. So today's topic, the stage 3A, what we see here, N2 disease, is the most challenging thoracic, the most challenging part of the thoracic surgery with respect to lung cancer. Next, coming to the definitions of the potentially resectable stage 3 lung cancer, this is from a landmark paper, one of the papers which is published in 2020 by UK. What we see is they have tried defining the potentially resectable stage 3 non-small cell lung cancer. They just give us the following 4 points that has to be confirmed pathologically, both the primary as well as the nodal status. It can be either in the form of endoscopy or surgery, and it has to be radiologically minimal. We have to get at least PET scan and MRI brain with contrast done. The surgeon should be competent enough and with a high probability to obtain a clear pathological margin. That's complete resection, what we see. And any nodal disease is discrete, easily measurable and defined, free from any major mediastinal structures, including the great vessels, trachea, with no individual lymph node measuring more than 3 centimeters can be taken up as potentially resectable. So now this brings us to what is unresectable. Whenever the goal of R0 resection is not achieved, then the tumor, especially the T4, we have invasion to mediastinal structures, which is generally not resectable. Exceptions, of course, with the advent of advanced in surgeries, minimal invasions into mediastinum pads, sleeve resections, bypasses, and atrial resections are now possible. Nodes, the N3 is unresectable, and those bulky N2 with extracapsular extensions are not upfront resectable. So now coming to this ESMO chart that depicts how we stage and risk assess our lung cancer patients. After the patient has first undergone the PET CT, he has to we come to know whether they have a mediastinal positivity or a negativity. If it's positive, either cases we have to undergo tissue confirmation. If it's straightforward N0 and there's a peripheral tumor, you can, of course, go ahead with upfront surgery. But in those cases where there is N1 and tumors are more than 3, we would prefer a tissue confirmation either in the form of EBUS or video-assisted mediastinoscopies, and the results will further depend on what the pathological reports come. Needless to say, multimodality treatment remains the cornerstone for our lung cancer patients. This is the same technique, but it further stratifies the N stage. We see that the N0, N1 go straight ahead with surgery, but if there is a case of unforeseen N2, we do give adjuvant chemo, and N2 which are potentially resectable after the multidisciplinary team assessment, we give a multimodality treatment in the form of neoadjuvant and then surgery. And the third one is there is infiltrative, and in 3 cases we straight away go with definitive CTRT. So this is another where we stratify our N2 disease as either to be found incidentally, which we give adjuvant chemo. Those which are single station resectable will be giving neoadjuvant chemo and then proceed with surgery. But those with single station unresectable and multi stations are given definitive chemoradiation with durvalumab. And if there's a residual disease, we'll further evaluate for henceforth. Now, in spite of this exhaustive workup plan with PET scans and the EBUS and the mediastinoscopies, why are there still an incidental N2 disease that is affecting our overall survival? To answer this, we have few theories which say that there are probably micromets There is involvement of inferior pulmonary ligament. Some of the areas like aortopulmonary ligament nodes which cannot be sampled by the routine technique, and a false negative invasive staging. This chart has been taken from ASCO, which clearly defines the T3N0, of course, falls in T2A, but the Pancreas tumors are given neoadjuvant chemo-RT and then gone ahead with surgery. These T4N0 cases, it can be either invasive or the non-invasive ones. Invasive, as in due to the size, has been labeled T4. These have to undergo multimodality, as already mentioned, neoadjuvant plus RT, and this is the multimodality. This is the single N2 locally advanced, again the same. Now, coming to the, I would like here to mention the two meta-analysis which have compared the preoperative chemo. Roughly, I would just like to point the things here that after the preoperative chemo for stage 3A, what we see is the path complete response was 0 to 6%. 5-year overall survival range somewhere from 17 to 36%, and downstaging of disease was seen from 17 to 61. The same with respect to chemo-RT in stage 3A. On this meta-analysis has given us the following results, clearly indicating the pathological complete response has improved. So somewhere favoring the trimodality treatment. But as we come on to the individual trials, this is a landmark trial published way back in 2019, intergroup 0139 trial, which forms the main treatment, which gives the main treatment for this stage 3 lung cancer. What we see here on the left side is the overall survival curve, and basically it had two arms where the pre-op chemo and radiation was given. One arm had continued with definitive chemo-RT, the other arm showed the surgery. The endpoint of these results showed that there was no significant difference in terms of overall survival. But there's a caveat to this as well. When the further substrate analysis was done for those patients who had undergone pneumonectomy and those with lobectomy, what we see here is the operative mortality was more with pneumonectomy, that is around 26%. But with lobectomy, we see the Kaplan-Meier curves are diverging, which showing thereby favoring the lobectomies in this patient. And what was drawn conclusion was that an unexplained exploratory overall survival analysis was added for hypothesis generation because of the unexpected high postoperative mortality rates. Now, patients were matched 1:1 according to their age, plus minus 5 years, sex, and their performance status, and the clinical T stage. So this type of analysis has led limitations because of the possibility of the differences that were not noted when the criteria were matched. So it should be used as the only basis for select treatment. Another chart from this trial shows the N0 status, that is the N0, N1, N3, and no surgery. We compare the overall survival in them. What was found that clearly N0 has a better survival compared to N0 patients had, pathological N0 patients had better survival compared to no surgery. But this caveat of patients were 1 to 3, N1 to N3, somewhere showed the overall survival of 24%, and in same patients, the CTRT was giving us 22%. So that's how I think the T3, N3 and the unresectable N2 turned up to be undergoing definitive CTRT. So this trial gives us a rough idea. So when should surgery be offered? It's when the patient is potentially operable, he's young and healthy enough for induction. The tumor response post-induction therapy is either stable or is decreasing in size. And there are ipsilateral hilar mediastinal lymph node status, that is the pathological status of it. And when a surgeon has completed enough, the tumor can be completely resected with a lobe, and this resection might provide for better long-term survival. Coming to another trial, this is randomized control trial way back in 2007 by Van Meerbeek. In this trial, what we see is, again, they had two arms of chemo-RT. Again, they showed that the progression-free survival and the overall survival was similar for both of them. So the conclusion drawn was surgical resection did not improve the overall progression-free survival. But again, when we go into the substrate analysis of this, we see that as a lobectomy and the pneumonectomies and all, the different parameters were compared. What we drew conclusion from this trial that the predictors for mortality, such high mortality in the surgical arm, were incomplete resection for pathological N plus disease and pneumonectomies. This is another trial which was again done and way back in 2015, and this it was closed prematurely. In this, we had a concurrent CTRT arm followed by surgery versus the definitive CTRT. What we see here is a 5-year overall survival was 44% in surgery arm and 40% in chemotherapy. Now coming to another trial which was published in 2020 by Dhara et al. In this, the trimodality treatment was again judged. What we see, they had divided the concurrent CTRT arms with no surgery, with lobectomies and pneumonectomies, learning from our previous trials, and they somehow gave the opinion that the trimodality therapy had a favorable outcome. We see that the Kaplan-Meier's are showing that the lobectomy is preferred over pneumonectomies than the CTRT arm. But there's another chart from this trial which shows that the nodal status, when there was less than 2 nodes, we clearly saw that the lobectomy, the diverging of these 3 Kaplan-Meier curves, but as soon as there were more than the bulky nodal disease, what we saw was that performing lobectomy was of course superior, but pneumonectomy was indeed doing worse than the no surgery arm. So what conclusion does this trial draw? That the persistence of YTN2 disease after induction is a poor prognosis per se. So we should focus on the pathological restaging of the mediastinum, and surgery should probably be beneficial in case of mediastinal downstaging, particularly in the form of lobectomies and complete resections. Now, next, that I would like to come to this meta-analysis of randomized trials conducted by McLennan in around 2015. What this tells us that all the outcomes of the patients of N2 disease with multimodality trials were, that is, the trimodality were included, and it had 1918 to 2013 was the time period. In this, the N2 disease who received induction CTRT, and they were randomized to either surgery or RT, and the main outcomes was overall survival. So this is a forest chart which is depicting that the trimodality trials favored somewhat surgery over the radiotherapy plan. So what was the inference drawn from this meta-analysis? That the overall survival was somewhat better for the trimodality. They showed a relative 13% improvement in overall survival. But for bimodality, we would still suggest both surgery and radiotherapy options are valid. And there's no statistical evidence of heterogeneity here. So again, I would like to say that every patient should be discussed in your multidisciplinary tumor board, and the dedicated centers for specific thoraco-oncology and thoracic surgery should only be involved in such cases. And as far as possible, we should avoid pneumonectomy. This is another trial which was published in 2017, which compared the definitive radiochemotherapy with surgery again as a modality. This is a meta-analysis where we see there were 8 studies. One was removed from the study, and what we see is the rest were only chemo. They were neoadjuvant chemo followed by surgery or RT arms. But these 2 trials we see here, the intergroup 0139 and the Espato trial, they had neoadjuvant CT-RT followed by surgery or radiation therapy. So what we see in this trial per se, that the forest plot showed the progression-free survival was favoring the trimodality treatment, but the overall survival somehow came out to be similar for both of them. But then again, a substrate analysis was done for the specifically patients with lobectomies, undergoing lobectomies, pneumonectomies, complete resections. How was the path CR response and the downstaging seen? What we observe in this trial is that the local recurrence and the distant recurrence rate was, of course, more with the definitive CTRT arm, but the postoperative rate was more with those undergoing pneumonectomies. We come to another landmark paper which is published recently in 2020 by UK. This gives us a timeline of the treatment and the percentages of the how UK is treating their patients right now, especially the 3A and 3B non-small cell lung cancers. Coming to the this table is again taken from the same paper, which tells us about the summary of the potentially resectable across the UK, European, and American guidelines. Basically, the gist of this table is that the US is favoring more of the definitive CTRT, while the European countries are more aggressive with their surgery part and the latest advances. What we need to know here is for the stage 3A. So Americans say that the definitive CTRT or induction is followed by surgery, but Europeans are not of the same opinion. And of course, the Americans have concluded that the preoperative chemotherapy is better than surgery alone in all small studies, and therefore surgery plus adjuvant chemotherapy is not recommended. But what our NCCL has defined these resectables? These are the low volume, lymph nodes, non-invasive ones, pathologically proven less than 3 centimeters. They have said that the benefit of pre-op chemo is similar to post-op, and either approach is justified. And they have added a maintenance durvalumab following CTRT for those undergoing definitive CTRT. So what are the lessons learned from the stage 3A and 2 non-small cell lung cancer? That there's probably no role of surgery alone right now in stage 3A and 2 disease. No apparent overall survival difference between the pre-op chemo and the pre-op chemo RT arm. Only responders that is stable or decreasing the tumor burden should get surgery. And only complete resection is beneficial. There's no role of partial resections here. Pneumonectomy is relatively contraindicated following the induction therapy in view of poor overall survival. Now I would like to come to the present era. What are the trends and outcomes of minimal invasive surgery for locally advanced non-small cell lung cancer with N2 disease? This paper was published by Herb et al. Being the primary investigation. What we see in this is approximately 5,800 patients with stage 3A and 2 non-small cell cancers had undergone lobectomies during the time period of 2010 to 2016. What we see that over the time period, the minimal access surgery rate has increased from 20 to 45%. And on comparing them with open, we saw the 90-day mortality and the 5-year mortality is somewhat better with the MIS group. We still yet to figure out the unmeasured factors. So what we concluded was in locally advanced non-small cell lung cancer, survival outcomes at least is similar among MIS versus open approaches. This paper was published in 2021. There are 2-3 charts I would like to discuss here. What is stage as the surgical approach for lobectomy for stage 3 has been discussed here. We see that open still forms the major chunk of the surgical arm. What we see is as the T1 stage increases, T1, T2, T3, the robotic and the minimal access stage, the minimal access surgery is a little difficult in those cases. And this will see over the time period how the trends have changed in the stage 3A and 2 non-small cell lung cancers. Like in 2020, where it was 20%, it has raised to 45% in 2016. There was another table in this paper which I would like to discuss. They were comparing the minimal access versus open and the robotic, that is the rats versus the VATs. What we saw that the 5-year mortality was of course more in open compared to the minimal access. And when both were compared, we could see that the VATs had more mortality compared to the robotic, while all of the parameters did favor the robotic surgery. So what the central message of this trial that minimal invasive lobectomy for stage 3A and 2 non-small cell lung cancer is increasing over time, and it is associated with at least similar short-term outcomes and better overall survival. What is the prospective statement? That we already know the benefits of minimal invasive for early stage, but there are only few studies which are showing its benefits in operable N2 diseases. Now this brings us to the latest paper, that is the Violet trial, that is video-assisted thoracoscopic versus open lobectomy. This, of course, is for the early stage lung cancers, but the findings can be extrapolated. This is another paper from the UK, which was published in Cancer in 2021, which showed that multimodality approach in minimal invasive can help tailoring the segmentectomy. This range from what do you call the 3D preoperative planning, that is the radiologically and the 3D constructions of the lobe that will help us find any anatomical variabilities to perform anatomical segmentectomies, to the preoperative markings like in the form of hook wire or dye, or virtual markings in the form of bronchoscopy. And these will in turn help us in better planning, locating, and with our minimal access as a team, not against each other, we can get a better segmentectomy done. So the gist of all this turns out to be that smaller resections and smaller incisions are in turn giving better functional outcomes, maybe in the form of VATs and RATs. So in our operating rooms, what we see right now is the VATs and the robotic setup. What we should, it turns out that the future debates are going to be whether it's going to be VATs versus RATs or surgery, rather than the individual treatment that we have catering right now. This table shows the features that the RATs is favored in terms of 3D confined space. We don't need a skilled assistant for it, but of course there are negative points that the accessibility of the equipment and the expense still adds. So I would like to conclude my debate with few of the slides. There's something called as Will Rogers phenomenon, which is seen. This is the process of stage migration which of course improves the outcome in each substate, but it is not improving the global survival. Now, we should remember that all those major randomized trials that were happening in 2007 to 9, they did not have the new staging techniques of PET scan that was shown, of course, to improve the outcome, thereby shifting the patients with occult met towards a higher stage. And another thing, these was based on the older staging classifications and procedures, and therefore they are not representative for the current population. What are my future perspectives from ERAS to ambulatory medicine? What this says that now presently we are in an era where ERAS protocol has come to its maximum extent, and now we can even have day-care thoracotomy with the present VATS and RATS procedures. We have to define a functional assessment because all this was in the era before the ERAS protocol. So what presently works for our patient has to be defined. There's something called a thinking green surgery, where we need a hybrid approach for the local treatment. It's no longer between the surgery versus the radiology or the chemo arm. There's a combined approach of all, including the minimal access, the innovative image-guided surgeries, and all to work together. And what do we say here by saying that respecting after innovative systemic treatment? We know that presently there are trials like Event and Alchemist going on, which are checking the neoadjuvant immunotherapy and the targeted therapy, their role in further stratifying the treatment plan. And what does it mean by providing adequate care for all? I would just like to conclude that giving this world-class treatment for your patient, but your patient is still not properly counseled about the smoking and is still smoking, so this all comes to fail. So right from the, the physiotherapist till the counseling, everyone is very important in the management of the lung cancer. And I would thereby conclude that this is a multidisciplinary approach. No one man is a hero, turns out to be a hero here, and everybody should be involved with the aim of overall survival, which was some years back around 9% to the presently around 22% for stage 3 cancer. Thank you.
Yeah, hi, Dr. Dhara.
Dhara,
Yes,
Yes, sir.
Prashant, go ahead.
Yeah. Dr. Dhara, excellent presentation. You have brought out very valid points and very important points on why surgery needs to be done in patients with stage 3A and 2 disease. And confidently brought out. Now, let's see from Dr. Zalak what she has to counter your arguments and put her foot down and say that CTRT is the treatment of choice. Okay, Dr. Zalak, do you want to start off with some points and then go to your presentation? However you wish. Its choice is up to you.
Sir, I'll directly go for my presentation and I'll cover one by one points.
Yeah, so we also wish that you could also do a rebuttal during your presentation. Is that okay?
Yes, sir. So, firstly, there is a big role of multidisciplinary team approach in case of lung cancer. This is a study, cohort study, which was done by Taiwan group in that national database that was including around 29,000 patients, and they found that in stage 3 and stage 4, multidisciplinary approach has improved drastically patient survival, but not for stage 1 and stage 2. So for stage 3 and 4, each and every patient should undergo for multidisciplinary team evaluation and followed by management. So this is the stage 3 of lung cancer. That is a very big heterogeneous group, and that big part is composed by stage 3B and 3C, in which N2 and N3 lymph nodal status has a big part. So this is the diagnostic evaluation, which my colleague has already shown. So we are not going to it. This is the chest physician of American College. They have defined a subgroup of stage 3 with extensive mediastinal involvement that excludes the ability for R0 resection, in which first is patient with directly infiltrative mediastinal stage 3 tumors. Another is patient with occult multiple N2 nodes involvement despite thorough preoperative staging, in which even through if we are planning for surgery in this group, ultimately R0 resection is might not be achieved, and patient will end up with having post-operative radiotherapy. So the plan of avoiding trimodality treatment will not be fulfilled in such patients. And third group is patient with discrete clinically evident by CT or PET-CT N2 involvement. Those patients should be discussed in multidisciplinary team and evaluated. So for potentially resectable N0 and one patient should undergo for surgery. Otherwise, patient with N2 disease, they should be discussed, or patient with unresectable disease, they should directly undergo for chemoradiotherapy. And for surgery, the main important thing is preoperative evaluation of for requiring lung resection. So with if patient is fit by this flow chart, then only we can consider surgery. And most of the patient who have already long smoking history, they have less pulmonary reservoir, and most of patients are unfit by this protocol. So we will see some randomized control trials. These are the trials which I am going to discuss. Most of trials are randomized control, and they have compared with or without surgery for stage 3. And main important thing is p-value, which is not significant for overall survival. Means whether patient has undergone for surgery or not, survival advantage has not been seen. So this is the landmark intergroup 0139 trial, radiotherapy plus chemotherapy with or without surgery for resectable patient. They have included around 450 patients, and they were randomized after giving preoperative chemoradiation for surgery or without surgery for definitive chemoradiation. And they found that although there is some progression-free survival advantage in surgical arm, but there is no such overall survival benefit has been seen. So we can say that in arm 1, means with surgery, patient might have some survival advantage, means progression-free survival advantage, but not overall survival advantage. This is another trial, SPA2 trial, in which patients were randomized after giving induction chemo, then concurrent chemoradiation, then either surgery or to definitive chemoradiation. They have recruited total 250 patients, but ultimately almost 75 patients were randomized to surgery and 75 to definitive chemoradiation. And from this Kaplan-Meier curve, we can see that both treatment has any major difference in overall survival. Means both are similar. This is another study conducted by Nsclc. He has given induction chemotherapy, and then patients were randomized between radiotherapy or surgery. So in this group, patient has received induction chemo followed by either surgery or radiotherapy. So this is the study protocol. And he also has shown that that neither progression-free survival or overall survival, there is no advantage of addition of surgery. So this is another trial performed by Johnstone. It is phase 3 study for stage 3 with mediastinal lymph node N2. He has given induction chemotherapy with 3 drug regimen, but mitomycin C was found toxic and it was later dropped. Then patients were randomized after receiving neoadjuvant chemotherapy to either surgery or either radiation with consolidation chemotherapy. And but this trial was inconclusive because of small sample size. But he hasn't. But the data of his patients hasn't shown any favor towards surgery or towards radiation. So this is the organ study, which has which is a meta-analysis for stage 3 patients, and he also has shown no benefit of in either arm, whether going for surgery or whether going for radiotherapy. Both arms are comparable. This is the forest plot of meta-analysis. we can see that there might be some progression-free survival because of inclusion of intergroup 013 trial, 0139 trial, and but the confidence interval was wide ranged. It was 0.73 to 1.13, and p-value was not significant. And for overall survival, we cannot find any advantage of surgery. So from this all trials, we have come to a point that we can say that whether chemoradiation or whether surgery, there is no added benefit of addition of surgery. So for chemoradiation, what should be followed, whether sequential chemoradiation or RT alone? For that, there is a CalGB 8433 trial, and in which 78 patients were allotted to chemotherapy followed by radiation, and 77 patients were allocated directly to radiation. And he has found that with RT alone, there is less survival probability. Means definitely there is chemoradiation has advantage over RT alone. So should we go for concurrent chemoradiation, or should we go for sequential chemoradiation? For that, Das Gupta et al. Has conducted a study for 100 patients, in which 3 groups were divided. In group 1, patients has received radiotherapy alone. In group B, they have received neoadjuvant chemotherapy followed by radiotherapy and followed by consolidative chemotherapy. In group C, patients has received radiotherapy concurrently with chemotherapy. This study's main purpose to define toxicity, and they found that patient in RT alone arm has better toxicity profile, means less toxicity, whereas patient receiving either sequential or concurrent chemoradiation, they have more toxicity. But there is not such a statistical difference found between whether sequential chemoradiation or concurrent chemoradiation in toxicity profile. They have also seen that initial treatment response and survival advantage, and they found that in RT alone, patient has overall survival disadvantage. They have less overall survival compared to patient who has received chemotherapy and radiation in either way, concurrently or sequentially. But there was no as such overall survival difference between either concurrent in sequential. This is another meta-analysis conducted by Ukraine for sequential or versus concomitant chemoradiotherapy, and that is also finding mild slight advantage towards concurrent chemoradiation side. But that was also not statistically significant, as p-value was 0.66 and for PFS 0.27. So if we are planning for going for concurrent or sequential chemoradiation, what should be the adequate dosage for radiotherapy? For that, RTOG 7301 has conducted trial way long back, and they came to a conclusion that survival probability is better with patients who has received 60-degree chemoradiation. Now another RTOG 0617 trial has been conducted to check whether addition of cetuximab or will improve survival advantage or not. But the study was not statistically significant for addition of cetuximab. And another is same RTOG study 0617. They have conducted a study to define modality of radiation delivery modality, whether in IMRT should be given or 3D CRT should be given. For that, there was no improvement in overall survival or any benefit. Only toxicity profile was better with IMRT, with only pneumonitis is statistically significantly less in IMRT. So from this, we can say that if patients are going under patients are undergoing for concurrent or sequential chemoradiation, IMRT should be chosen over 3D CRT. This is the Chartwell study to define whether hyperfractionation of radiation will give any advantage in whether in toxicity profile or in survival advantage. But not in disease-free survival or overall survival, both were not significant with hyperfractionation of radiation. But there was acute dysphagia and radiological pneumonitis were seen after the Chartwell study. Means with hyperfractionation, patients has more with suffered with pneumonitis and dysphagia. So for chemotherapy regimen for either sequential or concurrent, which should be chosen, whether etoposide and cisplatin versus paclitaxel and carboplatin, as concurrently with unresectable stage 3 patients. For that, we have found that etoposide and cisplatin has better overall survival, and that should be considered over paclitaxel and carboplatin. But grade 3 esophagitis was seen in our experimental arm, means with etoposide and cisplatin. Another is a Proclaim trial, which has conducted to evaluate the role of pemetrexed with cisplatin or etoposide plus cisplatin with thoracic radiation. Both arm has not shown any benefit in overall survival or progression-free survival. But the toxicity profile were different in both the arms. Grade 3-4 events were significantly lower in our experimental arm, which is pemetrexed with cisplatin, while pneumonitis was significantly higher with addition of pemetrexed. So these are the various regimens given in NCCN, which should be given with either with concurrent radiation or with after sequential radiation. So the patient who has undergone for definitive chemoradiation for stage 3A and 3B should undergo for durvalumab for at least 1 year from this study Pacific trial. That has given advantage of progression-free survival and also in overall survival over placebo. So in conclusion, we should definitely consider concurrent definitive chemotherapy for unresectable stage 3 or patient is unfit for surgery. But patient is even unfit for concurrent definitive chemoradiotherapy, then we should choose sequential chemoradiotherapy. But definitely from the trials I have already shown, concurrent chemoradiotherapy has benefit than sequential chemoradiotherapy. And if patient is even not fit for chemotherapy, then patient should be offered RT alone, then basic supportive care. And altered fractionation of radiation has no advantage of on our 60 gray radiotherapy. So this is untouched and a bit miscellaneous type superior sulcus tumor with T3, T4, N0, N1, in which actually N0 and N1 is there, so we can consider for surgery, but there is no randomized trial directly comparing definitive chemoradiation versus trimodality treatment. Only there is one subgroup, group, Southwest Oncology Group trial S02020. They have they have defined a protocol and patients were followed according to this protocol. Patients were given induction chemoradiotherapy followed by surgery followed by consolidative chemotherapy. But only 45% of patients were able to complete the planned regimen because of higher toxicity and low patients compliance. So from this study, we got the reasons for non-compliance, and for and some better protocol should be followed, and there may be some trials should conduct for better protocol for superior circus tumor. So this is my presentation.
Yeah, hi. Yes, Dr. Zalak, an excellent presentation to counter some of the arguments made by Dr. Dhara. So yeah, Dr. Dhara, do you have 5 minutes for rebuttal, and then we would give our comments. If you have any points
Yes,
for rebuttal.
I would like to defend myself again by saying that stage 3 being a miscellaneous group, no single modality is ever going to work. We have to work with hands together. And I would like to say that this time in EBM, Tata has mentioned quite a good chat about the rehabilitation of these patients, what we can provide, to decrease the mortality associated with the surgeries like lobectomies, pneumonectomies is as far as possible should be avoided. It starts right at the pre-op as well as the post-op setting. So I would put a highlight to that this can in turn help in reducing the mortalities that we are seeing in those trials that has shown that those intergroup and the other trials, those randomized trials during the era of 2005 to 9. Other thing is we didn't have the latest advances back then. Of course, I repeat the statement that the PET scan and the MRI have helped us to stage the patients with the invasive patch staging appropriately as compared to in those eras. And once again, sir, I would just like to confirm that no single person is a hero here. We just have to keep a common goal, the patient's overall survival outcome in the end. And we have to work as a team. But yes, of course, just like radiation therapy, surgery is also having its own new armadigans in the field. So we have to work together and get a better survival. That's all I would say.
Okay. Yeah, excellent, Dr. Dhara. So I think we have come to more or less, both of you all have made very interesting and important points. So it's not a one-man job, it's a multidisciplinary team. Both of you have concurred. I see that both of you did not debate. Both of you had made common statements, and it was excellent that, coming on to common statements in such controversial topic is something which is very, very important. So stage 3A N2 disease, as rightly mentioned, is one of the most diversified group of patients where you have, T1, N2, T2, N2, or even you have T3, T4, which is also stage 3A, which is actually, takes away a major burden also of the disease in stage 3A. So what we are looking at here is majorly the N2 disease part of it, because this is something which is more challenging. Okay, so with the current available evidence, whatever we have, it's an equipoise, N2 versus whether you want to do surgery or in case of definitive CTRT is equipoise. But remember, most of the trials have been conducted at a different time and era where the pneumonectomies were higher. So we do not have any as such data as of now. Yeah, so I'll leave it to Dr. Sarvana before I have a small presentation of around 4 or 5 slides where I'll be showing you. So Dr. Sarvana, your comments on.
First of all, I'd like to congratulate both Dhara and Zalak for an excellent topic. It's not easy to speak on this topic because even after so many years of being concentrated on this field, we are still not at a crossroads. We still find this challenge taking over in our day-to-day practice. I would like to make just a few comments because before Prashant takes over, and then after Prashant, I'll just end up with a few points as well. To Dr. Dhara, on a personal note, excellent talk. Your talk was very mature. You included most of the trials. You included most of the trials which are relevant and are evidence generating, and you included most of the meta-analysis. But I would like to suggest that these kind of meetings are actually for your personal improvement as well. So we should focus on our topic. We need not speak on just jump into the topic. So you should stick to your time. So if you look at the time given, it is 20 minutes. So always align your talk in such a way so that you just focus on topic. You could actually concentrate on subgroup survival curves. For example, I'll give you one instance. For example, if you see, when you separated in one of your studies, you separated the patients who had N0 and N1 to 3, the survival in those patients is very, very high compared to whatever survival is seen in chemoradiation was pure chemoradiation arm. So when you're talking in a forum where there is equipoise between two modalities, you should go into the subgroup, although it is not evidence generating, but in a debate, you have to prove your point. So you can go and tell that in an N0 situation or in a post neoadjuvant treatment N0 or N1 situation, these patients are definitely having a higher survival than definitive chemoradiation. So you should try to convince the audience that surgery is better. Second thing that you have failed to mention is an important aspect of surgery is the pathological response after neoadjuvant treatment, because that is coming up in a huge way. And most of us surgeons, when we give neoadjuvant treatment, neoadjuvant chemotherapy, be it chemotherapy or in the current scenario, immunotherapy or radiation, we want to know whether our surgery has been effective for that patient and have we selected the patient better. So that is an important point that you have missed. You should mention those things. And regarding Zalak, it's, speaking, you're a surgeon, I know, and speaking contrary to being a surgeon is a very difficult task. It's very, very important for us to know, because we are going to sit in multidisciplinary tumor boards in the future. And we must know about our colleagues, not our competition, our colleagues, because we are going to take decisions in the best interest of the patient. We should know about the doses. You have exactly mentioned those trials which mention the doses. You mentioned the sequence and the safety of the sequencing. Very good thing. You have not mentioned about the current gold standard for neoadjuvant for non-surgical based treatment for stage 3B, which is actually the Pacific study. I would have liked to have you involve that study, because currently the gold standard for non-surgical chemoradiation for non-small cell lung cancer stage 3 includes some form of immunotherapy. And I will let Prashant to take over now to give his study, because he'll give you a good clarity of what exactly we need to think when debating these topics in front of the patient. Thank you.
Yeah, thank you, Dr. Sarvana. I would like to share a small PowerPoint presentation and then take it forward. Yeah, just a second. Yeah, are you able to see my screen? Yeah. So yeah,
Yeah,
this
we are
is
seeing it well.
yeah, sure. So what we actually are interested in looking, just a second, let me just go back to the previous slide. Yeah. So we've all been talking about the standard N staging, N2, but there's something more important that we actually need to look at it when we are looking at N2, and this is what is proposed in the new AJCC. Like, this is what we are actually interested to look at. So just being an N2 disease alone cannot be denied surgery. It's important whether it is a single station N2 or or it is a multi-station N2, or in fact, for that matter, it is a multi-zone. So we know that the IASLC nodal classification has classified them into 6 different zones and 14 different stations. So a tumor with a multi-station and multi-zone is something which is completely different and which you definitely need to keep in consideration when you're planning for surgery versus concurrent chemoradiotherapy. Most of the trials which were mentioned by both the speakers are in an era where the staging was inappropriate. So most of them, we do not know how of them were like, the PET scan, the stage 4 disease and all those. So as of now, there is no level 1 evidence for surgery, nor surgery can be thrown away from the armamentarium. However, surgery is generally preferred in patients with single station, nodes less than 3 centimeters. And mind you, if a pneumonectomy is required in N2 disease, surgery should not be offered. And also the response to induction therapy, as Dr. Sarvana rightly mentioned, it is the pathological response also is very important following these group of patients. So response is always taken. So these are some of the options that we have when it comes to single station. Surgery followed by adjuvant therapy is not a bad choice. Induction chemotherapy and surgery is one of the choices, or induction chemoradiotherapy and surgery, or definitive chemoradiotherapy. So the only way when you can address or answer these questions is by means of doing something called as a network meta-analysis, because you don't have comparative arms between these two. So what do you mean by network meta-analysis for the benefit of residents? So when you have multiple options of treatment, but you do not know which is the best option. Like for example, in this, we have neoadjuvant chemotherapy followed by surgery, surgery followed by adjuvant, or you have concurrent chemoradiotherapy or plus chemoradiotherapy. So the network analysis with a common outcome generally tries to pull in all these, put them together, and then tries to tell. So in this network meta-analysis, if you see, interestingly, surgery has shown some important benefit, and this is a very important flowchart wherein the best outcomes were actually seen with trimodality treatment. Chemotherapy, surgery followed by chemotherapy, or chemotherapy, surgery followed by radiation, as you see in the right hand of the corner, is something that which are better for these group of patients. I agree this is not the best of the hands, but when you do not have direct comparison, this is something that which you should always take. But does this hold good in today's world with the immunotherapy coming in? We do not have the data. As Dr. Sarvana rightly mentioned, the Pacific trial is something that which has completely changed the outcomes. Adjuvant durvalumab for 1 year following concurrent chemoradiotherapy has completely changed the line of management in these group of patients with N2 disease. And at the same time, you should also remember the Checkmate 816 trial, which actually used neoadjuvant nivolumab, wherein compared to neoadjuvant chemotherapy, where the survival curves were completely apart, with median survival difference between 20 months versus around close to 30 months. So even now, at this stage where the immunotherapy has come in, we are again stuck. We do not have the exact data on which is better in these two group of patients. So as all these things have been covered already, so I wouldn't go through important points. When pneumonectomy is required, do not go ahead for surgery. Okay, so these are things where, okay, so this is a worldwide. Now we know that, we do not know whether surgery to be done or concurrent chemoradiotherapy. So this is a very interesting, guidelines which have been taken from different guidelines. This is from the 11 different societies which have been taken. So this makes it easy, because if you have a single station N2 disease and non-bulky, majority of them were for surgery or for concurrent chemoradiotherapy, but most of them went in for surgery. If it's a bulky disease, most of the guidelines do prefer concurrent chemoradiotherapy as the choice. But NICE guidelines and the UK as well as the ESMO still recommend neoadjuvant chemotherapy followed by surgery. For multi-station single zone, non-bulky, there is no doubt it goes for, most of them go in for concurrent chemoradiotherapy, whereas non-bulky disease, surgery, most of them do recommend surgery, either in the form of neoadjuvant strategies followed by surgery or this thing. Multi-zone is more or less same, but the data, we do not have data dividing these into multi-station and multi-zone, but it is predominantly mainly into non-bulky. So surgery in most of these guidelines still has some role. Okay, and consensus worldwide, this is again more or less same. As I said, bulky, most of them prefer to go for radiotherapy, because getting an R0 resection is something that which is very difficult in these bulky nodal group of patients. And with Pacific coming in, I would definitely prefer go for with consolidated durvalumab. I would go for definitive chemoradiotherapy in these group of patients. So this is one area wherein you have the multi-station, the non-bulky group of nodes where there is no consensus. So this is one station whether you can choose concurrent chemoradiotherapy or surgery in these group of patients. Okay, so resectable. So to conclude from my side, resectable single station, yes, NACT plus surgery versus NACT RT followed by surgery. NACT is better. Resectable multi-station, surgery versus CTRT. Most of the time, CTRT is a preferable. Unresectable or bulky, there is no doubt in concurrent chemoradiotherapy, and durvalumab should be considered post concurrent chemoradiotherapy. in all these group of patients. And finally, last but not the least, I think which I would give the most important, patient preference should be the most important key factor when both surgery and radiotherapy options are equally available. Because one of the things which most of the, both the speakers actually did not touch upon is the implications of salvage surgery post concurrent chemo radiotherapy. Okay, so this is something that which also is very important and needs to be considered. So the salvage surgery following concurrent chemoradiotherapy is something that needs to be considered when you are treating patients with concurrent chemoradiotherapy. Okay, and in the present today's world of molecular testing, it is mandatory because we know that there is data for giving adjuvant TKIs in patients even with early lung cancer. Okay, the famous Dhara trial, which has shown benefit in patients with adjuvant chemo. So there is definitely a role. So as of today, with therapies coming up, we are not very sure whether these patients should be completely, should be avoided surgery or not, or should go on to chemoradiotherapy. The only consensus as of today is yes, it is. Remind you, R0 is the key. R0 resection is the key, and avoid pneumonectomy as much as possible. If you have to do a pneumonectomy for a patient with N2 disease, then concurrent chemoradiotherapy is definitely a better choice. In all of the group of patients, you should try and use some new form of neoadjuvant strategies, and then a trimodality surgery definitely would be much more beneficial in these group of patients. Yeah, so that any questions and any comments from Dr. Somashekar, sir? Any comments?
Prashant, I'll just conclude fast.
Yes.
Yeah, we are short of time, so I think we'll just conclude fast. As Dr. Prashant has mentioned, it's a very heterogeneous group. And so we need to look at apples versus oranges, each staging, even N0, N1, T3, T2, everything is important in this situation. He mentioned about the nodes, the zones, and the bulky, everything you should know. An important point that we should know in managing N2 disease is patient selection. We have to have a good preoperative mediastinal staging, which is mandatory for all these patients. When we talk about these debates and when we go into practice, we don't actually focus on selecting the patient well, because these patients need to undergo mediastinal staging with either an endobronchial ultrasound or a mediastinoscopy prior to decision for even prior to the multi-tumor MDT board discussion. And not only that, if you have decided on some patient to undergo neoadjuvant strategy, restaging is also important, because you see in all the studies what you have noted is if we select our patients, the better selected patients do much better than patients who go for definitive chemoradiation. So suppose a patient had neoadjuvant treatment and all the nodes were vanished after neoadjuvant treatment, those patients are going to do better with surgery, and you should restage them well so that you select these patients who are going to have a good survival, just like as if they had stage 2 disease. There is a different, there is molecular difference. Definitely, like Dr. Prashant mentioned, in this current era, all the studies that we have mentioned, except a few in the end, were all done in the previous era where there was no molecular analysis, there were no invasive mediastinoscopic staging. And the most important point is surgeons have become very, very accomplished now. Most of the pneumonectomies which were mentioned in the era of the Albane trial, now we would have done sleeve lobectomies in those patients. So surgeons have become better, critical care has become better, and our mortality rates after complex surgery has become much, much better. So I think we need to wait for current, more number of studies are coming in the following years, which will give us an idea. And the additional thing is relevance to clinical practice in terms of cost. We have to select the most cost-effective treatment also for the patient. You just cannot give chemoradiation and then ask a patient to, take durvalumab when in certain patients, like the earlier N2 disease patients, where you can, give them good surgery and good outcomes. With that, I'd like to hand over to Dr. Somashekar. I think it was a good session by both the candidates, and I think it'll go on a long way to develop their career as well. Thank you, sir.
Super, fantastic, very beautifully analyzed. Questions are pouring in. Maybe 5 minutes, both of you can just open chat box Q&A. Prashant has answered a lot of them, I saw. Just see if they're unanswered. So in 5 minutes, we can conclude.
Yeah. So I'll just take.
Yes, so one of the, yes, Sarvana. I'll just put forward one of the interesting question, Dr. Sarvana. So should we do mutation analysis and PDL1 in all stages of Nsclc? What's your take on that?
Yeah, yes, in the current area, all patients of non-small cell lung cancer should undergo mutation testing, even if they are early stages who don't require adjuvant treatment, because it's very important. There may be failures even in stage 1 disease. So it's good to know from and the tests are best done when the tissue is fresh. So you should get it done.
Okay, and an interesting and important question from Dr. Krishna Kiran here. So what is like, do you treat these patients separately? What are the precautions that you take while doing a salvage surgery following concurrent chemoradiotherapy? Are there any specific precautions that you take?
Yes, when you're doing salvage surgery, especially if it's post radiation, you need to take care of many things. Number one, there are going to be a lot of adhesions, so be careful. Take the adhesions down with care. The second thing is, once you do the resection, make sure that you're not going to land up in a pneumonectomy, especially a right pneumonectomy. If a patient on preoperative imaging is going to undergo right pneumonectomy for clearance for R0 resection, I think you should avoid those surgeries. And the next situation is, if you do a surgery, all patients who undergo post-radiation surgery should have some cover of the bronchovascular stump, because they are very much prone for dehiscence. It's a very important thing, and you should do for all patients.
Yeah, before you treat these patients, because it is important to stage these patients appropriately and restaging if feasible. So one of the most important redo mediastinal something is associated with a lot of complications. So what we generally do if you have to do restaging, the first one is followed is an EBUS or an EUS, then some induction therapy, and then first time mediastinoscopy, which is used as a restaging. Because EBUS or EUS, the results are very poor following some form of neoadjuvant chemotherapy. So restaging is mediastinoscopy can be introduced at that point of time after induction, because patients with residual disease after induction therapy do very poorly, irrespective of what we do. So that is a real area of debate, whether you should be really offering them surgical modality at that point of time. So restaging is something which is also very important. Yeah, sir, I think that brings us to the end of all the questions in the chat box as well as in the Q&A.
Super, fantastic. Both Dhara, Zalak, beautifully done. When I was at your timeline, I would have been half able to understand this topic.
Yes.
To be frank, I'll tell you, mediastinum lung during our MCA training was nut and bolt in the brain. Out of passion, I remember going and purchasing a manual on lung surgery. It used to be like a A10 size page manual. I still have it. And then going and reading. But once you get into this topic, it's so exciting. You would love, and I also urge all the students, at some time of your career, please try to visit Shanghai Chest Institution, and in India go and meet Prashant and Tangam Cancer with Saravanan. This is a beautiful, exciting field, most challenging, not boring. Two fields which are very exciting is thoracic oncology and then peritonectomy hypec. Students should get exposed to it even if may not follow it. Thanks very much, Saravanan, Prashant, superb. I'm happy I'm not a student with you two as examiner. I would have got a 0 marks. But fantastic analysis. So proud of both of you. I'll tell you, two youngsters who excelled in this field, who are of international class in India, is both of you. I'm so proud. Thank you very much. Heartfelt thanks from me, my students, and on behalf of NBE board. Superb presentation, superb interpretation, both of you. Thank you, both of you, and have a nice day. A blessing is all we can give from students, which goes to you and your family for a fantastic work you both did. Thanks,
sir.
and over to Navneet Singh ji.
Thank you, sir.
Thank you very much, Dr. Dhara and Dr. Zalak, for the presentation, and thank you very much, Dr. Prashant, Dr. Sarvana and Professor Dr. Somashekar for joining us. And thank you, trainees and faculty members for joining us.